All right, colleagues, we move on with the next part of the second days. The next presenter would be Dr. Sarah Habibzadeh. She's Associate Professor of Department of Prosthodontics from International Campus of the School of Dentistry.
University of Medical Sciences.
And she has been in the field of prosthodontics for more than 10 years, and she's going to be the next lecturer. Dr. Habibzadeh, please move on. Thank you.
Hello, everybody. Hello, Dr. Sadafur. Thank you for your nice presentation. I will be sharing my screen now. Thank you. Okay, can you see me? Dr. Sadaf, would you have me?
Yes, please move on.
All right, everybody. Hello again, and thank you for being today with us. What I'm going to present for you for the next 30 minutes is about the digital workflow for complete dentures. As we know, advances in medical imaging, light and laser scanning technologies, and designing software have all contributed to a digital revolution. And the growing number of publications regarding CADCAM dentures, along with the manufacturers who are interested in providing these prostheses, is a clear indication of growing interest in the field of CADCAM complete dentures. We have several reports on various fixed prosthodontics fabricated by digital technology. We have inlays, onlays, endocrowns, fixed dental prostheses, implant abutments, even maxillofacial prostheses, but little data is available on complete dentures. And today we're going to have a review. We'll have an introduction to direct digital manufacturing. We'll see a history of complete dentures made by CADCAM. We will review the advantages and disadvantages of these dentures, and we'll have a look at the commercially available systems which provide us with a complete denture. And finally, I will go over the physical properties of these restorations and compare them to the conventional ones. Direct digital manufacturing, as we all know, started in 1971 with Duret introducing it into restorative dentistry, and the first CAD/CAM restorations were made in 1983. The procedure that we have for fabricating a digital process is usually consists of 3 steps. The first one is data acquisition, in which we have the scanning of our model. Secondly, we will go to data processing, and with the use of a computer and a software, we will plan our restoration. And finally, with the manufacturing device, we'll have our model rendered to a durable restoration. Previously, most CAD/CAM systems have been closed, which means that these 3 steps had to be taken into one manufacturer. You had to have the same scanner, the software, and the manufacturing device of the same company. But nowadays, flexibility between scanners, design software, and manufacturing devices are providing us with more open options. So you might have, for example, scanner from Trias in your office, and your laboratory might be equipped with an Ammann-Girbach milling machine. So you can work with these in an open system. For the scanning devices, we usually have 2 categories. We can do the intraoral scanning, or we can have the scanning of the impression or cast. Of course, the first one is preferred by our patients. They usually prefer to have the conventional impression making eliminated. And so with the use of intraoral scanner, it will be more comfortable for our patients. However, when it comes to CAD/CAM dentures, we're dealing with the mucosa. We need to take functional impressions, and to measure the differentiability of the mucosa, we sometimes have problems with these optical scanners. So we might want to stick with scanning of the impression or the cast. Our manufacturing devices also fall into 2 categories. We have the SMT or subtractive manufacturing. I'm sure my colleagues have spoken about these. And also we have the additive manufacturing or AMT. We can provide our complete dentures digitally with both of these techniques. SMT has long been in dentistry. With these devices, we will mill the shape of the restoration from a block, which can be a composite block, a ceramic block, or a metal block. And in case of complete dentures, it's going to be a pre-polymerized PMMA block. But we have some limitations with these technology. First one goes back to the milling machines. We have restricted motion capability, so we're not able to produce complex geometries and any motion capability. And the second one goes back to the material. So the block that you have to use with these milling machines should be tough, hard, and sterilizable. So we cannot have any material fabricated by CNC machining. Therefore, we have to go to the second technology, which is AMT, and generally named as 3D printing. We have other names for this: rapid prototyping, layered manufacturing. I'm sure you have heard of. And the last one says freedom fabrication. So as the name implies, we can have more freedom with the design and also fabrication. So we're able to fabricate complex geometries and structures with AMT. AMT can be provided various technologies. We have in AMT, we have selective laser sintering or SLS, we have fused deposition modeling, stereolithography, and also the ink-based systems. But going back to the digital denture, we have the glossary of digital denture, which says that a digital denture is usually a complete denture which is made through CADCAM and CAE. The history of making these restorations goes back to 1994, in which Maida and his co-workers, they created a plastic shell of the dentition and a record base from photopolymerizing resin, and later the denture teeth, which were fabricated from tooth-colored composite material, were bonded to this. But this article presented by Goodacre and his co-workers was the first one to validate the clinical procedure to make a CAD-CAM complete denture. And in this article, they actually fabricated a prosthesis for a patient with the use of a 3-axis milling machine. So this was the first article to provide us with the details of making a CAD-CAM restoration. Comparing the clinical steps of a conventional denture and a digital denture, we see that in order to fabricate a conventional denture, the least we have is a 5-step appointment process. So if we're lucky and everything goes well, then we'll have the preliminary impressions in the first session, then we'll have our final impressions. In the third session, we'll have the jaw relation records, and finally, we'll have a denture in wax, which will be tried in the fourth session. And if everything is okay, then the 5th session or appointment will be the delivery of the denture. But with commercial CAD-CAM systems, most manufacturers claim that we're able to provide our patients with a restoration in only 2 sessions. So the first one, for the first appointment, will be data gathering, including impression taking, jaw relation records, occlusal plane orientation, and also selection of the tooth mold and shape. And we will have our denture ready by the 2nd appointment. So this is fascinating. Most of the manufacturers, though, provide us with a trial denture between these 2 sessions, which can be tried in, and any modifications can be performed on that trial denture and rescanned again for the final denture. So therefore, the advantages of having a complete CAD-CAM denture consist of having a reduction in the appointment visits, which is 2 or mostly 3. The fabrication fees will be comparable or even lower than the conventional dentures. One of the most advantageous features that we have with these CAD-CAM dentures is the ability to restore the data. So you can have the impression making and the jaw relation records in only 1 clinical session. You can have all these data stored and then use them to have a spare denture or a replacement denture for the patient, or even a radiographic or surgical template. So you don't need to go over the clinical steps again. You have all these data available. And the other advantage goes back to the material that we use with this technique, which I'm going to talk about this at the end of my presentation. The blocks that we have with this technique has a superior fit, strength, and less residual monomer compared to the conventional ones. We will talk about these later. Of course, we have several disadvantages with the CAD-CAM dentures. Sometimes we have problems with the occlusion because we have to take all these information in only one clinical session. So we might not have an exact occlusion as we have with our conventional dentures. So we might need a clinical remount. The clinician has to be well experienced. If you're not experienced enough, this could result in unsatisfactory results because we're taking all the information and data in only one clinical step. Of course, we need temperature resistant materials, and most of the time we will stick to additional silicone, which are polyvinyl siloxane. And the last disadvantage, which is a lack of trial placement appointment, has been covered by the manufacturers. And nowadays, most of the manufacturers provide us with a trial denture that can be tried in, and any necessary modifications will be performed on this. All right, if you want to have a quick review on the available CAD/CAM systems, when I had this presentation like 4 years ago, I believe, the only available systems were the first two, the Avident and Dentica digital dentures. But nowadays we see that several companies have provided us with CAD/CAM dentures. You see Amengerbach in this list, you see Vita, Ivoclar, and Dentsply. So we see that inevitably we will have complete dentures made digitally in our offices. The first manufacturer of complete denture is the Avident digital dentures provided by Global Dental Science. They use a subtractive manufacturing technique, and they usually provide us with two options for our complete digital denture. So the denture can be a milled denture base from blocks of resin, and then the denture teeth will be bonded to it, or we can have a monolithic denture in which both denture base and teeth are milled with the use of a 5-axis milling machine. And we have separate materials for these. For example, for the base, we have pre-polymerized PMMA, and for the teeth, we have an extremely cross-linked resin. And these two will be actually built as a single unit. And we have mono and polychromatic options for the denture teeth as well. The advantage of this system is that it can provide us with several prostheses. So with only one clinical session, you can have a complete denture, a provisional one, single arch complete denture, a conversion denture. You might have immediate or hybrid prostheses made, implant supported over denture, even record bases, verification jigs, and also radiographic and surgical templates. So this is quite advantageous because with only taking one impression, we can have all these prostheses made. The clinical steps will usually take place in 3 sessions. So we'll have our data gathered in the first appointment, then we'll have our trial denture in the second one, and finally, we will deliver the denture. In order to obtain our clinical records with Avident, we have several options. First of all, we can use the previous dentures of the patient as a reference. So this is the reference denture technique. We can have special protocol called the Avident Wagner EZ guide, in which we have printed bases. I'm going to explain these in my following slides later. We can have an intraoral scanner and take everything digitally and eliminate the conventional impression. Or we can have the conventional records, vice versa. So in this final option, we will have everything conventionally, our primary impression, second impression, even the occlusal rims, setting of the teeth, and finally we'll have a wax denture, which will be scanned and milled. So these are the magnetizing EZ guides that I already talked about. If you want to use this option for taking the impressions and the record bases, you will have these 2 bases printed in the second appointment. So you see the maxillary one has the 6 anterior teeth set in a thin layer of wax, and the posterior teeth as well. For the mandibular one, we have a base which has the 6 anterior teeth on it and a posterior wax occlusion ring. So with the use of this, you can check the impressions and also have the records, centric and VD. All right, if you want to use an intraoral scanner and take your impression digitally, this is also possible. It is highly suggested to mix PIP with zinc oxide and paint it on the mucosa if you want to do the scanning, and this will improve your accuracy. We have several articles validating this procedure, and if you want to use an intraoral scanner, then you'll have a true mucostatic impression. So this will not be a functional impression, and this is only mucostatic, but it will produce acceptable results. We also have the suggested scanning pathway in this picture. If you see, for the maxilla, it usually starts from the hard palate going to the crest of the ridge, and finally the buccal and vestibule. But for the mandibular one, it starts from the crest of the ridge going to the buccal and lateral vestibule, and finishing with the lingual vestibule. If you want to take the maxillary impression with an intraoral scanner, it will usually take 2 minutes, and for the mandible, it will take 5 minutes because we have to go and perform multiple attempts. Some authors prefer to have their mandibular impression in a conventional way because when we want to take the impression in mandible especially, we have to define the border extensions, we have to measure the differentiability of the mucosa, and this is not possible with an intraoral scanner. So you might want to stick to the conventional procedure, or after making the impressions and fabricating the final prostheses, you might want to go under a conventional reline procedure, especially for the mandibular denture. All right, with the evidence, we start out first appointment. In the first appointment, we usually have an introductory kit, which has these trays. These trays are thermoplastic, so you can put them in the water bath, and they're completely moldable. So you have the option of taking the preliminary and final impression with these at the same time. Another thing that we have in our starter kit is the anatomic measuring device, which you can see in this picture. And actually, let me have my laser pointer. Okay, so these are the AMDs, or anatomic measuring devices. And finally, we have these mold tabs, which are used to select the tooth mold and size. So if you're lucky and you have the previous denture of the patient, you can have a putty cast from the previous denture, and then these trays will be molded into the putty cast. So finally, you'll have your tissue stops with the use of an intraocclusal registration material. You have your border molding with the heavy body polyvinyl siloxane. And finally, the final impressions or definitive impressions with the use of light body polyvinyl siloxane. So later we use the AMD to measure the OVD, maxillary lip support, midline, the desired occlusal plan, centrifugation, tooth size, and incisal edge position. So you see that in this picture, we have an adjustable stylus for the maxillary AMD. We use this to measure CR and record this via the Gothic arch tracing method with a central bearing pin. And also the maxillary AMD has an adjustable lip support, which is used to adjust the lip support of the final denture. So with the mandible, we have a flat occlusal tracing table. You see this in the picture. So this is the table on which the centric relation will be recorded via the Gothic arch tracing method. We'll see in the following slides. So we will secure these AMDs with the use of an recording material in the patient's mouth. And in order to stabilize them and parallel them as possible as we can to the infrapupillary line, the system provides you with a ruler. So you will align this with the interpupillary line of the patient. And after that, vertical dimension is determined in a usual manner. So here we have the, for example, modified Niswanger technique to measure the VD. And CR is recorded. So you see that we have some intrusion material placed on the flat occlusal table of the mandibular AMD. And the patient is asked to perform function. So he moves his jaw forward, backward, and to the left and right. So we'll have the CR on the mandibular AMD. As you see, this arrow, which is the center of the arrow, it denotes CR. So finally, we'll set the lip support, midline, and small line with this adjustable flange that we have here. And we have these selection tabs. We can place them on the previous denture of the patient. They come in various sizes. You see, we have the average size, small size, or large size in different molds and different actually sizes. Or you can place them on the maxillary AMD in the patient's mouth and secure them with flowable composite. After these information are gathered, we will inject the recording material between the maxillary and mandibular AMD. And finally, we have this to be scanned. So this will provide us with all the information that we need in only one clinical appointment. So from this, the software that we have with the Avadent will build the occlusal relationship. They will build the denture borders, define the borders exactly, form the intaglio surface, form the denture bases, and also the software will virtually set the teeth according to your desired occlusion, which is usually a balanced occlusion. In the second appointment, we'll have a trial denture, which can be used to evaluate aesthetics, phonetics, functional components, retention. So everything can be checked, and these are usually made in bags, so you can make any adjustments necessary and then rescan these for the final denture. So as you see, we have several options for the trial denture. We can have the previously described Wagner EZ guide. We can have a milled trial denture with the teeth on it, or we can have a milled denture base in which the denture teeth are set in a thin layer of wax. And finally, we can have a printed resin trial denture in a monochromatic shade. But the interesting thing about these trial dentures is that when we ask our patients and our clinicians, in terms of aesthetics and stability, they would prefer the traditional and conventional trying dentures. So they're not very comfortable with these new CAD-CAM made trial dentures. After this, the final base will be milled. So you see that it has special recesses into which the dental teeth will be bonded. We will place the dentures. It can be from any manufacturers. We can mill them ourselves, or we can use, for example, from Ivoclar or Vitadent artificial teeth. So these are placed in the recesses and bonded, and finally we'll have our final denture. So this is the third appointment. We will provide the patient with a complete denture, and the procedure of delivering it to the patient will be completely the same as a conventional denture. We will check the intaglio surface for pressure spots. We will check the occlusion and also the aesthetics. So the second manufacturer for CAD-CAM dentures is the Dentica, which provides us with additive manufacturing. So these are usually printed bases, and denture teeth will be bonded to them. This system can provide you with complete dentures, partial dentures, single arch, and immediate dentures. So our options were actually more complete with the Avadent digital dentures. It also starts with the introductory kit. So we see we have special trays again in this starter kit. They come in various sizes, and as you see, these are detachable. So you can detach the posterior and anterior part of the tray. So the first appointment will be border molding and impression taking with these trays. And after that, we will separate the anterior and posterior part of the tray, as you see in this picture. And the anterior part of the trays, as you see, are more like the AMDs, which we use with the Avadent digital dentures. You see that in the mandibular tray, we have a central bearing pin, which is used for Gothic arch tracing to measure CR. And we have a flat occlusal table on the maxillary tray, which serves as the plate to record against interpolation. So we'll have the OVD determined, and finally centric relation. So here's the tip of the arrow, and it denotes CR. After everything is verified, we will have our registration material injected between these two trays. So you see, with the use of these special trays, we have the impressions and the records simultaneously. So these will be scanned, and our software will virtually set the teeth. So in the second appointment, we will have a trial denture, which is usually printed. We will check these and check the aesthetics, phonetics, everything else that needs to be verified. And finally, the denture bases will be printed. So there again, with a special recess, we will polish these denture bases, remove the excess, and the denture teeth, which are again printed, will be bonded to these. So here are our denture teeth, and these will be bonded to the denture base. So we'll have our final denture ready for placement. And again, the delivery will be the same as a conventional denture. All right, the other company to provide us with digital dentures is the Ivoclar. I'm sure you've heard of these companies. So it also uses a subtractive manufacturing protocol, and the procedure might take 3 to 4 appointments. After taking the impressions and the jaw relation records, we usually have a trial denture, which is usually fabricated from a block of white opaque resin. And the special feature about this CAD-CAM dentures is that the system provides us with a special face bow, which is called the UTS CAD device, and is a basic face bow which is used to help the clinician measure the Camper's line and also align the denture with the interpupillary line. So this is used to orient the occlusal plan in a desired way. And Ivoclar can provide us with 2 types of complete dentures digitally. So the first one, as you see, is a denture base, which is milled from a block of PMMA, which is called the Ivo base CAD, and the denture teeth are also milled from a special dual crosslink material, which is called the SR Vivodent CAD, and these 2 will be bonded together. And the second option that we have with Ivoclar is seen in this picture. You see we have a monolithic denture, which is milled from a bicolored special disc. This is called Ivoshan, and it has the base on one side and the denture teeth on the other side. So this is a special disc which is used to mill the Ivoclar dentures in our second option. We also have Amann-Girrbach, which has integrated with other 2 companies, with Vita and Baltic Denture System. The software that we have with Amann-Girrbach is called the Ceramil Full Denture System. The interesting feature about this system is that it provides you with wax dentures. So you have your information, your data gathering, and the denture will mill the denture from a wax block. So finally, you will try these wax blocks in the patient's mouth, and if everything is okay, the denture will be conventionally processed. So you see that in this technique, we don't have milling or printing of the denture, but we have conventional processing. So as I said, Vita has integrated with Amann-Girrbach and uses the milling machine that they have. If you want to use Vita complete dentures made digitally, you usually have 2 options. The first one is your denture, which is milled from pink PMMA block, and the artificial teeth are again from the Vita company, and these will be bonded to the base. The second option that you have is a milled wax base, and the denture teeth will be set in wax again. So this provides us with the option of being able to try this in the patient's mouth, make any adjustments necessary, and finally process the dentures conventionally again. We also have another system called the Baltic Denture System, which uses the Amann-Girrbach milling machine. With this system, we have special trays. You can see them in the starter kit. So they come in various sizes, and these are called the BD key trays, and they have special locks on them. So with the use of these trays, you can have a functional impression and also record the jaw relations, your centric relation, and also the vertical dimension. And another interesting feature about Baltic dentures are that the system can provide you with a denture which has a lingualized occlusion. All right, the latest entry into the world of CAD-CAM was made by Sirona. Sirona made 3D printed dentures, and they used a special resin called eloxytone. We have a special protocol for bonding the denture teeth into L'Occitane. So that base is printed and you will have the denture teeth bonded. They usually have a chemical bath in which the denture teeth are immersed, and then they use a bonding agent. They light polymerizing it and place an external sealer to have these teeth bonded to the printed denture of L'Occitane. Okay, the last part of my presentation goes back to the materials that we have for these CAD-CAM dentures. We always wonder whether these CAD-CAM dentures are as suitable as the conventional ones. So in terms of hydrophilicity and wettability, we see several articles stating that these CAD-CAM dentures have a lower contact angle, which means they're more wettable and they're more hydrophilic. And this usually provides us with two advantages. The first one is improved retention. So it could be quite satisfactory for those patients with salivary dysfunction. And the second one is less bacterial adhesion, which is quite advantageous. Another concern that we always have is the residual monomer. So we wonder whether the residual monomer is more or less with these new CAD-CAM dentures. You see that it usually causes denture porosity and it has some adverse reactions on the soft tissue. So one article stated that the high pressure and temperature that we usually have for the fabrication of CAD-CAM dentures provides us with longer polymer chains. So we have a higher degree of monomer conversion and lesser porosity, therefore less residual monomer in these CAD-CAM dentures. So regarding the surface roughness, we know that with both conventional and CAD-CAM dentures, we have surface roughness. We usually want to avoid this because it causes surface staining, plaque accumulation, and bacterial adhesion. So literature suggests that when it comes to milling dentures, then the sizes of the ripples and surface roughness depends on the quality of the milling machine. And we have several articles stating that these CAD-CAM dentures have a smoother surface. And on the other hand, we have articles stating that there are no significant differences between these two. Another important feature is the denture base adaptation. What do you think? Do you think that our CAD-CAM dentures are more retentive and more accurate than the conventional ones? Of course, they're more reproducible, and with conventional PMMA, we have some volumetric shrinkage. A recent study by Goodacre suggested that between different processing, CAD-CAM press, pore, injection, and CAD-CAM techniques, not one of them provides the perfect tissue-based adaptation, but CAD-CAM dentures have a more accurate and more reproducible denture made. So again, we see the literature, we see that CAD-CAM dentures have a better fit, they're more accurate and more retentive. And an interesting article was presented by Yoon and his co-workers. They said that if you want to compare the milled and 3D printed bases for the complete denture, you have no significant difference with regards to tissue adaptation, but our milled bases produce a uniform tissue adaptation versus the printed bases have more compression on the posterior ridge crest and buccal shelf, so they will need some chair time adjustment to remove these compressions. So if you want to put this all together, we might suggest that for the patient for whom retention is the primary concern, CAD-CAM denture would be a better option. Regarding the color stability, we know that our dentures undergo some color changes over time, and this is usually due to the inherent water absorption property of the resin that we have. As the material which is used for CAD-CAM complete dentures is highly condensed and it has minimal porosity, we expect to have less color changes with these dentures. And a recent article approved this and said that we do not have noticeable color changes with these. But another study by Goodacre suggested that we have color changes and stains on both milled and conventional dentures. And if you want to have the most color stability, you're going to have to choose the monolithic teeth and denture bases. So they're the best regarding stainability and color stability. Again, another article by Gruber and his co-workers suggested that The printed ones are the worst with regards to color stability, and these bases usually have the maximum color changes. We usually have no concern regarding the flexural strength. Actually, these dentures are completely acceptable, and they have a very good fracture toughness and flexural strength. And a systematic review on the physical properties of these new dentures suggested that overall they have a superior physical property compared to the conventional processed complete dentures. But how about our patients? Are they more happy with their CADCAM dentures or the conventional ones? We see the literature suggests that the overall satisfaction and assessment with these CADCAM dentures is usually excellent. We could have some complications as with the conventional ones. We have lack of retention, problems with vertical dimension or centrifugation, and even pressure spots. And a recent article stated that 40% of the prostheses made by CAD/CAM needed relining. All right, that was a very brief review on what we have on complete dentures. As I said, inevitably we'll have digital dentures in our offices, but usually they're the last in line. These are my contact information. If you have any comments or questions, I would be happy to answer. I would also like to take the opportunity to thank the organizers of this short course, especially our course director, Dr. Farid, my honorable colleague, and also Dr. Shaki Vanis, as the international.
All right, thank you so much, Dr. Habibzadeh.
Can you hear me?
Wonderful presentation.
Thank you very much.
It was very informative for us, and nice picture from the Paradise Dental School.
Yeah, this is my dental school.
We're happy to have you here.
Thank you very much.
If the audience have any question, please let us know, and you can type it in the message box and send it here while Dr. Habibzadeh is here. So we are looking forward to hear from your questions.
Sorry, I didn't hear what you said about me.
I
missed the best part. Of course, I should say your lecture was very comprehensive, very new, and thank you so much for your very good gathering of the data. We hope we can have this lecture again.
Thank you very much for having me
for
today.
Advanced graduate students here, so hopefully they have it once here.
And also the audience for staying with us today. Thank you very much.
So is there any question coming up from? We're gonna move on with the next lecturer.
Then I have to say goodbye. Thank you again, and have a pleasant presentation for Dr. Morshadi as well.
Dr. Habibzadeh, unfortunately, I can hear you.
Okay, I'm stopping.
All right, we move on with the next lecturer, which is Dr. Erhan Morshadi. He graduated from Tehran University Medical Science in 2010. Then he received his master in prosthodontics in 2015. And since that time, he's teaching as an assistant professor in Zanjan University and recently in Tehran Dental School. So, Ehsan, please carry on. Thanks for coming, and we are ready to listen to your wonderful presentation. So we have two more lecture to go on. The first one is by Dr. Morshadi, and the last one, Dr. Kazemi will join us in half an hour.
Hello to everybody. I have to say hello to everybody, and thank you to Dr. Habib Zadeh. That was a great presentation. That was very useful for me, and I suppose that was very useful for other audience as well. Okay, I'm Dr. Morshadi. I'm prosthodontist, and this is a view of Tehran, the city where I was born, where I grew up and graduated from dental school. And this is the main entrance of Tehran University of Medical Sciences. Of course, this is the main entrance of medical school, and the entrance of dentistry and pharmacy schools are at the left and right side of this entrance. Okay, let's get into the webinar. My webinar will be just an overview about what digital implantology is. It's not very detailed. I think all the prior presenters have warmed you up, but my presentation is somehow a cooling down presentation. I'm going to say just a few words about digital implantology, and it will be, I guess it will be interesting for the ones who are has just entered to digital implant dentistry. What are the advantages of digital implantology? The advantages of digital implantology is that we can program and plan where to place the implant, and we can plan the depth of insertion, the direction of insertion, and also the angulation of the implant placement. Other advantages are some additive values such as time saving for both the patient and the practitioner. In the conventional or traditional way of implant treatment, we have several sessions with the patient, from consultation and oral examination to final crown. You almost have 7 visits: surgeries, suture removal, second surgery, and healing placement and healing abutment placement, impression making, and temporary crown, and even final crown. But in digital implantology, the number of sessions are decreased. We have one session, and in this session we evaluate the patient remaining bone via CBCT and X-rays, and also we have intraoral scans as digital impressions. And in the second visit, we place the implants in the patient's mouth, and also maybe deliver some temporary crowns for him or her. And after some months, we can deliver the final crowns. The other advantages of digital implantology is that because mostly, not always, but usually our surgeries are done flapless, so the blood in the oral cavity is lower than the traditional way of implant placement. So the patient is more comfortable with this procedure, and so the dental assistant needs to turn the suction lower in the oral cavity. So minimum noise will be there in the patient's mouth, and also the operation time will be reduced. And the key point and one of the most important advantages of this procedure is minimum damage to adjacent structures. It's important when we are placing implants close to other roots. We are placing implants there in the minimum bone remaining bone, and also we have nerve proximity or sinus proximity. In these cases, we can place the implant exactly in the place we planned before in virtual software case. This slide from my point of view, is so important. This slide shows all the process we do in digital implant dentistry. In the left picture, in the left images, you can see a CBCT device and also an oral scanner device. These two devices takes two digital images for us. One of the digital images is the intraoral scan, which we call it digital impression. In this digital impression, we have all superficial tissues in oral cavities, such as tooth crown and also a superficial surface of the mucosa and also gingiva. The second digital image is CBCT, and it includes some inferior parts like bone and roots and nerve and sinus. So we have some common points and some common images in these two digital images. In the oral scan, we have teeth, and also in CBCT, we have teeth again. These common points are the key points that helps the software to merge these two images on each other and produce a digitally single image. So in one single image that is merged by a software, from those common points, such as tooth structures, we have different tissue, different oral cavity tissue parts, such as teeth, soft tissue, the surface of the soft tissue, the surface of the bone, and where the nerve is placed, where the sinus is placed, the thickness of the bone, the height of bone, and also because we know where the surface of the soft tissue is placed, and also we know where the surface of the bone is placed, we can calculate the thickness of the soft tissue. And this is the key point that helps us to examine and produce the final or customized abutments, because we know to producing the final customized abutments, we have to know the gingival height. In this single image, we can calculate the thickness of the gingiva, and the thickness of the gingiva is a key point to deliver exactly after to deliver the final abutments exactly after the surgery is done. And what are the stuff that is produced for us? The stuff that is produced for us, there are some different materials, from surgical guide to customized abutments or the final temporary crowns, which are made usually from PMMA resins. Here is the intraoral scanners that most of us use it or know about it. You can see we have a surface scan of oral cavity. In this superficial scan, we have both soft tissue and hard tissue. The hard tissue is the teeth. After merging the intraoral scan into the CBCT from the common point, that we say the common point is the tooth, we have one single image from mucosa to bone, and we can plan where the implant has to be placed and design the final restoration and final abutment, and also the surgical guide. And our materials will be milled or printed. In the library of the softwares, we have different brands of implants and different dimensions and different length of implants. We can choose our patient brand of implant from the library and virtually do an operation on the patient's images and place the implant in the proper position. In this slide, I have to explain a series of different type of surgical guides for guided surgery in dentistry history. At the left, you can see the very initial type of surgical guides that were made from orthodontics resins and also plaster casts. The second type of surgical guides were made from printing materials, but the casts were also plaster casts. The lab side scanners scan the cast, and the software designed we could design the surgical guide on the scanning image, and after that we could print the surgical guide instead of the orthodontic resins. But in the last generation of the surgical guides, all the process is digital. At the first stage, initial guides were non-digital, they were fully analog. After a period of time and development, they were semi-digital, but the last generation are fully digital surgical guides. You can see the misfit in the non-digital surgical guides, and the misfit is reduced in semi-digital guides, and fully fit surgical guides in fully digital surgical guides. Okay, I have to explain a little bit about the differences between the traditional or conventional way of do implant treatments for the patients and the newer way that we call it digital way for implant placement. In the conventional way, as all of us know, the patient at the first session is referred to the surgeon, and surgeon after some intraoral examination and evaluating the patient CBCT sets the surgical session for the patient. At the surgical session, the surgeon inserts the implant in the proper position as he knows that is the best place. And after some months, patient is referred to the prosthodontist for prosthesis. So this type of surgery or implant treatment is called surgical driven implantology. But in the newer concept, we do implants in the prosthetic driven manner. In the newer concept, patient is referred to the prosthodontist at the first session, and the prosthodontist evaluates the prosthesis that patient needs and make some impressions from the patient mouth and designs the proper prosthesis in the software. So in this stage, regardless of where the implant is going to be placed, the prosthodontist designs the prosthesis in the best position and best condition ever it can ever. After designing the prosthesis, the prosthodontist, by consulting with the surgeon, virtually places the implant beneath this prosthesis he designed. And after placing the implant in the virtual space, the surgical guide is produced. And the surgical guide has some sleeves on it that directs and guides the drills during surgical session to how deep it should go, how straight or how angled it must be. And because we design all the process prior to any incision in patient's mucosa, we can produce all the stuff patient needs, such as customized abutments, such as temporary crowns, such as surgical guide, such as TI-based abutments, or anything we need. In this image, in this slide, you can see an intraoral scan. Also, you can see two ceramic markers at buccal and lingual side of the molar region and one at the buccal region of the anterior teeth. These are not very useful in patients who has their teeth in their mouth, but it is mostly useful in the patient completely dentulous. These markers helps us to merge the two images of intraoral scan and CBCTs on each other by the software. In this slide, you can see the merged image on the intraoral scan, the merged CBCT image on intraoral scan. So we have both soft tissue, hard tissue as bone and teeth, and we could place the implant in its proper position. The process is prosthesis to implant. It means that we design the restoration before placing the implant, and after designing the restoration in its proper place, we choose where the implant should be placed. This is the prosthetic-driven implant surgery. Again, we can see both two images merged on each other. The mucosa, the teeth, and also bone hard tissue. This is the surgical guide designing in the virtual space. You can see the surgical guide sleeve, which is a cylindrical runway for the drills that guides the surgeon how deep to drill and how angulation, how much angulate the drills. These are also, you can see in the middle of this slide, the temporary crown and also the final abutment. Sometimes the surgical protocol could be delivered by the demand of the surgeon, or it is usually not needed for surgical process, but if the practitioner asks, it could be delivered for the practitioner. And also another material that could be produced for us is a transferring jig, which helps us to transfer the abutment to the mouth, to the proper direction and rotation in the mouth. And placement of the crown, and everything is done. I hope this presentation was interesting for you. This was just an overview about digital implantology. I hope it was interesting and useful for the ones who were getting to digital implantology. Any questions? I will get your service. Dr. Farid, can you hear me? Dr. Sadehpour, Dr. Farid, can you hear me? I do not have your voice.
Unmute. Yeah. Do you have my voice? Now, can you hear me? Can you hear me, Dr. Morshadi? Can you hear me? Hello, Dr. Again.
Pardon me, I didn't have your voice. I couldn't hear what
now. Mute.
Okay, if the audience has any question, they can type it in the typing box. I will give you service.
Can you hear me, Dr. Morshadi?
Yes, now I can hear you.
Thank you for your very nice presentation. It was very great. Thank you so much. Can we get the audiences ask, can they get your PowerPoint?
Yes.
Can they have your PowerPoint? Of course,
yes,
we have
yes.
recorded.
I have my PowerPoints are available for all the audiences.
So perhaps it will be very good if you type down your email or something like that. They can, or you are on Instagram.
Yes, I do have Instagram, and I will I will give my email to all audiences if any questions were.
That will be very okay. So they can be in touch with you, and they have said that you have amazing presentation. Thank you.
Thank you very much.
And
Thank you very
they
much.
wanted your presentation.
Thank you
I
very
also,
much. That was an
I'm so
honor.
thankful too.
That was a great honor for me to be at your service, to be here with you, very good, talented teachers, and hope to see you in the next tours.
Yeah, we hope to be with you again because it was very interesting, and thank you so much. And thank you for accepting our invitation, Dr. Morshadi.
You're
And
welcome. Thank you a lot.
it was a great pleasure to have you with us. So we go to our next lecture, our next Thank you so much for staying with us. This will be our last lecture, and I hope you have enjoyed our program. And today, this 2 days program was actually the theory part of our theory and practice, practical short course on digital prosthetic dentistry. We hope we see you here for the practical part. Our last speaker is Dr. Mahmoud Kazemi. He's going to start his presentation in a few seconds. And if there is any question about the program or anything else, we are here to answer your questions after the lecture. So Dr. Kazemi.
Thank you, Dr. Farid. I think I can start, yeah?
Yes, please go on. But we don't have your view.
Okay.
Video. Oh yeah, now we have it.
It's okay? Dr. Farid? Dr. Farid?
Yes, it's okay. Please go on.
Can you hear me?
Yes, of course.
Thank you. Hello, everybody. I want to talk about customized abutment. Customized abutment. What's customized abutment? I should first explain what is customized abutment. Customized abutment is an abutment which has been made for a prosthesis in the implant patient with gingival level following the marginal level following the gingival level of the implant, and the height exactly for the prosthesis which should be made on it, and the tapering that is enough for it, and the contours is proper for the prosthesis with the best emergence profile and with the best angulation to correct the angulation of the implant to become an abutment straight that a prosthesis can sit on it. This is a customized abutment, and each customized abutment may be made only can be made for one implant with this situation. So it's customized abutment and cannot be used for other implants. The history of customized abutment. Here you see some abutment we know as stock abutments. For example, a straight abutment, angulated abutment, and so on. When we use, for example, angulated abutment in a fixture is not in direction in these cases, we should use angulated abutment. Again, maybe sometimes we milled some part of these abutments, and as you see, we cannot have good retention and stability even with very strong cements. So if we can have a customized abutment, we can solve this problem. Sorry, I should, yeah. Here we can see one customized abutment in the right side, and other one is not customized. It's a stock abutment, angulated, and is milled a lot to making it parallel to long axis of the tooth in this place. Here is designing of customized abutment by some software like ExoCAD and etc. tree shape. You see that here with angulation abutment, we have angulated implants. We have a parallel abutment with diameter proper for the restoration, for example, for a molar, for a premolar, and the gingival level of the finishing line of the abutment you can see here. And this is the designing of the prosthesis on it. This is the customized abutment. And about the history of the customized abutment, I should say, sorry. Okay. Yeah. Yes. The first abutment we used for customized abutment was UCLA abutment in 1980s. That in that time we used this abutment. It has three parts. One part is the metal part of it. We use for connection to implant, engaging the implant, and the other part is a plastic tube and a screw on it. This is the three part of the UCLA abutment. When we want to use this UCLA abutment, first we cut the plastic tube to adjust it with the opposing tooth and make a clearance, occlusal clearance. And then by wax or resin, we add to it to shape it as a abutment we need. And then we can cast it. In casting procedure, the metal part should be tolerate a high temperature of casting, and it make it a little deformed, a little bit deformed, and the deep oxidation need to clean it, to polish it after casting, and all of these make its intimacy a little bit lesser than that should be for connect to implant. So we have a little micro motion in the implant with this UCLA abutment. And also in baking the porcelain in the oven, porcelain oven, again we have some shocks on metal part of the UCLA abutment and make new layer of oxidation that all make lose the UCLA abutment on the implant. for many years after use of the UCLA in each patient, we face this problem, and these problems make us to use other customized abutment for the patient. No, it is very rare we use custom UCLA abutment as customized abutment. The next one here, the next one problem with UCLA abutment is when we use it as a splinted abutment, when 2 or 3 implants are splinted together by the prosthesis, which prosthesis is screw type. Never we can find 2 implants be exactly parallel with each other. So the connection cannot sit on 2 implants that are not parallel exactly. So seating is a problem. The technician in the lab cut some part of this connection area and mill some part of this connection area, and the intimacy of the connection between abutment and implant lose. We lost some part of the connection, and it made that it have micromotion, and finally we can have a complete seating of this framework on the implant. The only way, this is the implant after using UCLA abutment with chrome cobalt alloy, which mills some parts of the connection area in the implant after for example, 6 months in use. Other choice of us for making a customized abutment is using milling abutment. Milling abutment is manufactured by the implant system manufacturers, and like other stock abutments, like straight abutment, angulated abutment, ball abutment, also they make milling abutment. Milling abutment has thicker walls to make room for milling each side you want, and then make parallel abutment and to form it as you need. But there is, but we need a milling machine here. You see it here, milling machine, and this milling machine mills some walls, some part of the abutment to make it as a customized abutment. But all of this should be done by hand, and it's take a long time, and it's make a very high pressure, high force on the connection between the implant and abutment, and the connection part of the abutment should tolerate this force, and the screw is better to change for the use in the patient months for final cementation. Anyway, it takes long time, and its diameter is not so much to give us a chance to make any abutment with each angulation. About the customized abutment, this is the customized, this is a pre-milled abutment or a blank, titanium blank. This is made of titanium alloy, and each pre-milled abutment or each titanium blank has 3 parts. One part is the connection part of the abutment to the implant, and other part is fixing part to the holder of the milling machine, CADCAM, And the third part is here, that is for milling, to making an abutment. Some part of this is for transmucosal area of the abutment, as we say, gingival height, and the other part of it is to making the abutment that is intimate with prosthetic part, as you see here. The machine will prepare it. I can make it bigger to see you. Yeah. As you see, after designing the customized abutment, in the milling machine, the machine mills it to form a customized abutment. Some of the burrs are roughly milled and some make a smooth surface on it, as you see. I said the holder is there, which the pre-milled abutments are fixed in this place, and it's making a smooth surface. Okay. This is the holder of the pre-milled abutment. Some milling machines have different holders. Some have, for example, this is this model, or another models are, so we should have the pre-milled abutment that is compatible with this holder, or the laboratory should have the holder that is compatible with your pre-milled abutment. As you see here, it's a custom abutment. It's not a custom abutment, it's a stock abutment which has been fractured, because when they were in the lab, they want to make it, they should mill some part of the this abutment and make it too much thin, and so it has been broken. But if we use milling abutment, we never have this problem, because we can make thicker abutment in other parts to strengthen it, and never it can be broken. Other advantages of the customized abutment is that you can make all the abutments of the full arch restoration parallel, and so can use one piece restoration on it. So you can distribute all stresses almost equally on all of the implants. So you have not stress concentration on the 1 or 2 implant. And this is other way we should talk about it in maybe in next session. Okay, and also in customized abutment, we have customized healing. Customized healing is useful for forming gingiva around the implant before impression making. Before impression making, you use this to form the gingiva, and the emergence for profile is the best for this solution. So the advantages of customized abutment in digital manner is that we can make implants precisely for a restoration with parallel wall, with good marginal level, gingival line, and with good emergence profile, good contouring, proper contouring for the restoration. But we have 2 common mistakes about the customized abutments. One, someone thought that if we use a thicker customized abutment, in cases we should use cantilever pontic. If we use thicker abutment, so we can decrease the length of the offset force, the offset area, the cantilever area of the restoration, but it's not correct. Our main reference for distance of the cantilever area is the implant margin, implant margin distance to neighbor to next tooth. And this is the way of the measuring the cantilever size, not the abutment diameter. And other common mistake about the customized abutment when we use UCLA abutment or milling abutment is that they think when 2 or 3 implants should be splinted with screw type prostheses. We can use non-engaging UCLA or milling abutment. Non-engaging UCLA or abutments just let you to rotate implant and without any engagement. But it never help you if it's not sit to help you to sit the prosthesis on the abutments. Abutment does not sit on the fixture, on the implant, and this problem cannot be solved by using non-engaging UCLA or non-engaging milling abutment. In the using of digital customized abutment, we should always use engaging abutment, not non-engaging. So the manufacturer of the implant system always make premise abutments engaging, not non-engaging. Thank you very much. If any question is, I am ask you, I want to answer if there is any question.
Thank you so much, Dr. Kazemi. It was very good, very nice, and very informative. Thank you so much for actually accepting our invitation. We hope see you on our next programs too. Thank you so much. And if
you're welcome. Thank you so much for inviting me.
You're welcome. It was our great pleasure, and we hope we see you again on our programs.
I hope so. I hope so.
Yeah, we hope so too. Is there any question, dear audiences, colleagues, students? If there is any question, please write it on the chat box. And if there isn't, it's time to say goodbye, and we will send the certificates to you by email. And we hope we see you on our program, on-site program for the practical part. And we hope you have enjoyed our program, and see you soon, inshallah. Bye, everybody.